Imagine the people responsible for planning your local hospital services, your doctor's appointments, your community health centers. Now, imagine that in the space of just 2 years, 65 out of every 100 of them are fired. Not retrained, not moved, just gone. This isn't a dystopian fantasy. This is the brutal reality hiding inside the Labour Party's proposed 10-year plan for the National Health Service. It's a plan laid out by Shadow Health Secretary Wes Streeting in a massive 168-page document. It's filled with grand promises of a modern, efficient, and patient-focused future. But what is the real price of this vision? Today, we're tearing apart this plan, guided by the sharp analysis of David Winskill, the interim chair of Healthwatch. We will expose the gaping holes, the deafening silences, and the truly shocking decisions buried in the fine print. In this deep dive, we'll ask, what happened to the crucial chapter on how any of this will actually be delivered? Why is the plan to slash the National Health Service's back office staff so severe it's forcing a radical, unprecedented centralization of power?
And most alarmingly of all, why does a plan that claims to put patients first involve abolishing the one independent organization in England whose sole job is to be the voice of those very patients? Stick with us as we uncover the story of a plan that could either save the National Health Service or shatter it. At first glance, Wes Streeting's vision seems like a breath of fresh air.
It's full of what one commentator called parenthood and apple pie proposals, ideas so wholesome and sensible, who could possibly argue? The plan talked the big game about shifting the entire focus of the health service. The new mantra is prevention, not just treatment. It's about stopping you from getting sick in the first place rather than just patching you up afterwards. This is a noble goal, a holy grail that health experts have championed for decades. Imagine a world with fewer chronic illnesses, a healthier population, and less strain on our treasured hospitals. The plan also promises to bring care closer to home. Remember the idea of the polyclinic? A one-stop shop in your local area where you could see specialists, get tests done, and access a range of services without having to track to a massive impersonal hospital? That concept is back on the table, promising convenience and community-focused healthcare. And of course, there's the relentless march of digital technology. The plan envisions oodles more digital for everything imaginable. From using big data and artificial intelligence to manage the health of entire populations, to advanced digital tools for faster and more accurate diagnosis. Even booking a simple appointment to get your feet done is set to be streamlined through new apps and online systems.
On the surface, it's a vision of a sleek, modern, proactive National Health Service. It's efficient, it's local, it's preventative. It's everything we've been told we need. But as with any grand political promise, the devil is not just in the detail, it's in what's been left out entirely. And the silences in this 168-page document are deafening. Let's start with the most critical partnership in healthcare, social care. This is the system that looks after our elderly and most vulnerable. The system that provides care in the home that allows people to leave hospital safely and with dignity. It is the bedrock upon which the entire National Health Service stands. The plan's silence on social care is, as David Winskill puts it, deafening. Without a fully funded and integrated social care system, hospitals remain clogged with patients who are medically fit to leave but have nowhere safe to go. This is the infamous bed blocking that paralyzes emergency departments and creates record-breaking waiting lists. The promise of care closer to home becomes an empty, cruel slogan if there is no social care to support people in their homes. It's like planning to build a beautiful, state-of-the-art skyscraper, but completely forgetting to design or build the foundations. But the omissions don't stop there. In a twist that sounds like something from a political satire, the plan was originally supposed to have 10 chapters. But when it went to print, only 9 made it. And the phantom 10th chapter? It was titled Delivery. That's right, the single most important chapter, the one explaining how these grand ambitions would actually be implemented, how the vision would be turned into reality on the ground, simply vanished. What we are left with is a blueprint with no instructions. There is little to no detail on how the crucial revenue funding streams will be changed or reformed. The government can promise the world,
But without a clear, sustainable plan for where the money will come from year after year, it's just talk. There is one small glimmer of hope mentioned, a welcome announcement of longer financial planning cycles, which could give National Health Service trusts more stability. But this is a tiny detail in a vast sea of uncertainty. And what about the people? The plan calls for radical new ways of working, with more care delivered in the community. This requires a massive shift in skills for doctors, nurses, and other clinicians. Yet the plan contains almost nothing on how these dedicated professionals will be retrained for these new roles. Who will teach them? Who will pay for it? When will it happen? Silence.
And perhaps the biggest question of all, where will the capital come from? The promise of new polyclinics and community health centers is wonderful. The need for new MRI scanners and diagnostic equipment is urgent, but these things cost billions of pounds. Other than vague mentions of public-private projects, a phrase that often sends a shiver down the spine of those who remember the costly and controversial private finance initiative deals of the past, and property disposals, which means selling off existing National Health Service land and buildings, there is a complete silence on how this new infrastructure will be funded. It's a plan full of expensive promises, with an empty wallet. This is where the story turns from concerning to truly alarming. While the plan is silent on where new money will come from, it is brutally explicit about where money will be saved. And it's being saved by cutting the very people who make the system run. Last year, the existing government told the National Health Service Commissioners, the groups known as Integrated Care Boards, or ICBs, who are responsible for planning and buying health services for your local area, that they had to lose 30% of their running costs. This meant, primarily, losing staff. It was a huge blow. But then, earlier this year, in what the author describes as an ostentatious curtsy to the Daily's Mail and Telegraph, Labour leader Keir Starmer announced a further, brutal 50% cut on top of that. Let's do the maths, because it's simple and horrifying. Imagine last year, your local ICB employed 100 people to plan services, manage budgets, and understand the health needs of your community. The first 30% cut reduces that team to 70 people. Then, the next 50% cut doesn't take 50 from the original 100. It takes 50% from the remaining 70. That leaves you with just 35 people. From 100 planners and commissioners down to just 35. A staggering 65% reduction in the workforce responsible for the strategic direction of your local National Health Service. This isn't trimming the fat. This is amputating the limbs and scooping out the vital organs of National Health Service management. The very people whose job it is to make sense of these complex changes are being shown the door in droves. If you find this level of cuts to healthcare planning not just shocking, but fundamentally reckless, do hit that like button to let us know you're with us on this. So, how did these decimated organizations respond? How can a team of 35 possibly do the work that 100 used to do? Their answer is as logical as it is terrifying. They merge. Across England, ICBs are discussing mergers, huddling together for survival. For a while, it was assumed that London's complex network of health bodies would be safe from this. The capital's health economy is just too big, too complicated. But that assumption was wrong. Last month, it was announced that the North Central London and North West London ICBs are now formally exploring a merger. If this goes ahead, it will create a single, monolithic organization of almost unimaginable scale. This new mega ICB would stretch across 13 London boroughs. It would be responsible for the healthcare of 4.5 million souls. Let that number sink in. 4.5 million people. That is more than the entire population of Scotland or the Republic of Ireland, all managed by one single commissioning body. It would easily become the biggest and most powerful ICB in all of England. And here we arrive at the central, mind-bending paradox of Wes Streeting's entire plan. The plan's stated goal is to reconfigure care, to move it out of big hospitals and into local community settings. It's about empowering neighborhoods and being responsive to local needs.
Yet the direct consequence of its funding cuts is the creation of the most centralized, distant, and colossal decision-making body the English National Health Service has ever seen. How can a single board, overseeing 4.5 million people across 13 boroughs, possibly have the granular, local knowledge needed to deliver care closer to home? The task is made near impossible by the fact that 65% of the planning and commissioning staff, the very people who held that institutional memory and deep community knowledge, will have been let go. The expertise, the relationships, the understanding of local health inequalities are being drained from the system at the exact moment they are needed most. It's a recipe for a profound and dangerous disconnect between the architects of the new National Health Service and the communities they are supposed to serve. But the plan saves its most inexplicable and arguably most cynical decision for last. Amidst all this chaos, this centralization, this loss of expertise, you would think that strengthening independent oversight would be a top priority.
You would think that ensuring patients have a powerful, independent voice to hold this new system to account would be paramount. The plan does the exact opposite. It proposes the complete and total abolition of Healthwatch England and all of its 151 local Healthwatch organizations. Let's be clear about what this means. Healthwatch is not just another part of the National Health Service bureaucracy.
It is a fully independent body with a legal mandate to be the champion of the patient. Its staff and volunteers listen to the experiences of real people in their communities. They conduct research, they visit services, and they produce evidence-based reports on what is really happening on the ground. They offer a valuable signposting service, helping people navigate the bewildering complexity of the health and social care system. And crucially, they provide a fully independent voice for communities, a way to challenge decisions, to investigate problems, and to hold both care providers and the powerful commissioners to account. So why on earth would you abolish it? According to Wes Streeting, the kind of independent, proactive, research-based advocacy that Healthwatch currently offers pales in comparison to the granular, highly actionable feedback collected in other service industries. Think about that statement. The voice of the community, the lived experience of patients suffering from a misdiagnosis, the systematic gathering of concerns about care quality in a nursing home, all of it is dismissed as inferior to the kind of feedback you might give on a pizza delivery app or an online shopping order. As David Winskill, who is himself the chair of a local Healthwatch, Riley puts it, "Oh dear, this isn't just a policy change, it's a fundamental shift in attitude. It's a move to sweep away the organized, independent, and sometimes inconvenient voice of the public and replace it with what exactly? Data points? Online surveys?" The very idea of an independent patient watchdog, a critical friend to the National Health Service, is being cast aside. This is a critical moment for patient rights in the United Kingdom. If you believe an independent voice is essential to a safe and accountable health service, subscribe to our channel. We will be following how these plans develop and what they mean for you and your family. So, where does this leave us? As David Winskill concludes, there are some genuinely fabulous ideas in Wes Streeting's 168-page plan. The focus on prevention and community care is laudable. The drive for digital innovation is necessary. But the entire project is built on a dangerously unstable foundation. It's a vision plagued by an awful lot of hard, unanswered questions. How will it be delivered? How will it be paid for? How can you deliver local care by creating giant, centralized bureaucracies? And how can you claim to be building a patient-led service while simultaneously dismantling the primary engine of patient voice and accountability? This isn't just a plan, it's a high-stakes gamble with our most cherished public service. The author leaves us with a simple, stark warning that we should all heed as this political vision moves closer to reality. Watch this space, because what happens next won't just be a political headline. It will define the future of the National Health Service for a generation to come.